health. My primary functions and duties are to service medical equipment. I maintain them in every aspect. I calibrate the equipment. So in essence, I am not an engineer. I don't design or implement, but I take care and maintain the equipment in the hospital. So for instance, the images you see on the screen, there's numerous devices right there. So within those devices, I am responsible for, like I said, ensuring patient safety, patient care, the safe and effective use of the devices. I assist with the setup of the devices. Occasionally I'll proceed with utilizing the devices with the physician and staff who need assistance with those devices. I'm also an adjunct professor at IUPUI, so I've taught for healthcare engineering technology management. In the program they have there, teaching biomedical equipment technicians some basic entry-level courses along with some higher-level courses. I've taught for the CIT department over at IUPUI as well, teaching some basic networking fundamentals, some security fundamentals as well. I'm also a researcher, so I do a little bit of work for some not-for-profit organizations. They do, they're more in depth in research and design. They're looking at cybersecurity within medical devices and systems. So the research is driven to find what vulnerabilities exist, how can we mitigate, and really developing a framework and a plan as we move forward here in the future. So with this presentation, I don't want to treat it as a lecture. I'd like more of a discussion. If you have any questions, again, I'm from the healthcare field, so I may use acronyms, I may say phrases or things that don't make any sense whatsoever. If you encounter something like that, please stop me and ask, okay? Yes, sir?
So, healthcare, of course, is a critical infrastructure.
Yes.
Just like transportation and electrical distribution. Has the government, has the federal government, engaged the national labs to look at how to make some of this equipment more secure from a cyber perspective?
Yes, there are presidential directives in order to help increase awareness. And I've got a whole slide on that I'll cover a little bit more. But yes, there are initiatives to increase the awareness. They're trying to fund money into programs to increase education. Also, they're looking at more of the manufacturing side, almost from the embedded side, where when the devices are being developed, what the manufacturers should look into. Yes, sir.
So I know for control systems, they have like NIST standards. Do they have similar standards yet?
Not yet. Not yet. That's the challenge. So in healthcare, it's a little bit different. So it's hard. We have to, again, work with patients and patient safety. So some of those standards, as far as the healthcare atmosphere within a delivery organization, are different. Now, through manufacturing and some of the other critical infrastructures, yes, they have adopted some of those practices. Okay, so you've mentioned the critical infrastructure, and as a whole, and I do have a slide on here indicating all the different facets of healthcare. And so when I also talk about some of the numbers or project some of the numbers, I'm referring to the critical infrastructure as a whole. So when we talk about some of the attacks, where they came from, the high dollars and values, it's not just from a healthcare delivery organization or hospital. It's, like I said, from all. So I'll jump into that here in just a moment. Okay, so the evolution of healthcare, it's drastically changed. It's different than it was 10 years ago, let alone 30 years ago. So we are fast-paced and we are looking to get our devices to market. We want to increase patient safety, increase patient satisfaction. We want to ease workflow for clinicians, make physicians happy. There's a lot of factors here. So with the evolution of healthcare come the latest and greatest technologies. I mean, everything from radiotherapy to different kinds of MRIs and technologies to help increase, like I say, patient care. So here's a kind of a broad overview of our national infrastructure in healthcare. So like I said, when I talk about some of the intrusions we've had, some of the numbers and figures, they come from all of this. So you can see we have laboratories, blood and pharmaceuticals, and they just come from anything from drugstore chains to blood banks, any kind of association with those organizations. We have medical materials, so device manufacturers, distributors, things like that. Health information technology. So one of the biggest here is electronic medical record systems. Right now, those are the biggest players in the market as we have moved forward to having every healthcare organization we can move into electronic medical records and integration and interoperability. Federal response programs. So we have coordinated response activities and other federal partners, including the Department of Homeland Security. Then we have our direct patient care, which include healthcare systems, professional associations, medical facilities, and consumers and consumer devices, and some medical emergency services, mass fatality management services. We have our health plans and payers, This is the other big factor. You're going to see a lot focused in that area because those are our covered entities. Those are our third parties that we deal with, that healthcare organizations deal with. That's who pays our medical claims. That's where a lot of our information is stored. So if the hospital doesn't have it, it's sitting with these payers and other providers, the clearinghouses and whatnot that are behind closed doors that you guys don't typically see. And again, our public health and our public health sector. So governmental public health services. So when we talk about healthcare, when we think about healthcare, we think of some of the latest and greatest technology. And as you can see here, it looks like the physician or surgeon is wearing a VR headset, performing surgery. The healthcare industry and where we've moved with our devices is unparalleled. I mean, it's drastically changing. We are trying our best to increase revenue, increase patient safety, at the same time create less invasive procedures to increase efficiency and patient safety and satisfaction. So the medical device industry is about a $228 billion industry right now. They estimate by 2020, the year 2020, it'll be about $447 billion industry. So for a lot of medical devices, the approach is first to market. We want cutting edge, we want first to market. Our medical devices are turning into IoTs, or they have many other definitions right now. But about 15% of all medical devices are smart. They have some sort of interoperability, some sort of communication built in. We want our devices wireless, we want them Zigbee, however we can to get them to communicate. So healthcare delivery organizations and hospitals also have about 300 to 400% more medical equipment than IT devices. So again, as I bring up those numbers and facts and figures that I'll get to here momentarily, most of this has nothing to do with an actual medical device, a therapy device, a diagnostic device. It has everything to do with the IT systems, the front-end facing servers, the web servers, all those. So those are our basic IT systems. So we haven't even touched what could possibly happen once we get to these 300 to 400% more medical devices that are in a facility. The global smart medical device market is worth about $66 billion right now, or by 2024 compared to $33.7 billion in 2015. That's for smart devices, devices that are communicating. The devices that currently aren't communicating, we are looking at ways, or we have implemented ways, middleware, to create interoperability, to get these devices to talk. We have devices that are 10, 15 years old that have serial outputs. They have ways of delivering information. We just use a piece of middleware to extract that information to put it on the network. So yes, 15% of medical devices are now smart, but in reality, about 70% of them we're trying to get to communicate some way, shape, or form. So technology is driving healthcare delivery. So we talk about mHealth or mobile health. I don't know if you guys have seen commercials. You've gone to your physician, you've gone to your providers, and they're trying to push your MyChart. They're trying to push you, get online, check your stuff. Why don't you download an app? We live in a digital era where our patients lack communication, they lack awareness, they lack an understanding of their own health. Physicians, if you realize, they don't really spend a whole lot of time with you. They don't get much time with you, maybe 15 minutes if you're lucky. So what they often try to do is get you to utilize these tools that you have in your pocket, tools that you have at home to kind of monitor yourself. So the mHealth is the newest digital era of things. So being able to download applications, being able to monitor, input your information. Physicians can now even electronically communicate with you with those apps. They can view that information. We'll get to the security side of that in just a moment. But we also have telemedicine. We have rural communities that simply can't have physicians on site. They're just not staffed for that. So with these rural communities, we often utilize telemedicine. So if you need a diagnostic procedure done, you need a computer tomography scan done or an MRI scan done, they may not have a radiologist on site. So they will send that information out, whether it be to a Nighthawk anywhere. That individual or that organization could be in India, they could be in some other country, they could be, again, anywhere, wherever they contract with, because it's cheaper, it's easier. We'll pay per scan or we'll pay per reading rather than have a staffed physician on site. Then we have our electronic health record, which is right now our massive digital era. It's our digital warehousing, our big data and analytics. We're going to get to a point where we're going to be warehousing so much information, we're not even going to know what to do with it. And then when someone does get their hands on it, like they are currently, it's invaluable. There's so much money involved in this. We don't even know how to handle this in the healthcare industry. We've got so many players to the game coming along trying to get and having you install and sell EHR systems that we don't often know what happens. We don't know where it goes. We don't know how to set it up. So you have a lot of small-time healthcare providers in rural communities, again, that aren't involved with these larger organizations like IU Health or those kinds of organizations, or my organization. So they'll buy a small-time electronic health record system from a small vendor. It's a little bit cheaper for them. That vendor may be somewhere else. They may store that in the cloud. They may not have patient privacy in place. We don't know, but that's what's happening as more providers and more are jumping on board with EHRs. And then social media. We share everything now, don't we? We share absolutely everything. We put it on the internet. We put it everywhere. We're doing the same thing with our health information. So the social media kind of boils back down to the mobile health as well. But that's where a lot of that's where healthcare is going. So you can see the tablet there. Our ambulance drivers, they're inputting your information on a tablet as they're bringing you to the hospital. So by the time you arrive to the hospital, the physician's there. He's got a general idea of what's going on, the signs and symptoms, so they can get you moving a little faster into the facility. Now, implantable medical devices is the next greatest thing. It's been around for many years, but the problem is we're implanting them everywhere now. So we can almost take over major bodily functions by implantable medical devices. Some of you probably know someone who have an implantable device. Right now, these are a big security risk because for one, once they're surgically installed, they don't come out very easily. They typically last about 10 years. In order to get these devices in, they're placed surgically, but to make changes or reconfigure them, it's usually done wirelessly. So our physician will have a programmer, or a rep with a physician will have some sort of a programmer that will wirelessly connect to one of these devices, and when changes are made, it's done wirelessly. There are several experts in the field who have debunked this and found how easy it is to crack and hack that and to steal patient information, even modify and make changes to these devices while in vitro, while they're in the body. Medical researchers like Dr. Kevin Fu, he's done numerous studies on implantable pacemakers and defibrillators where he's able to deactivate them wirelessly. He's, like I said, can make changes. So imagine a family member who's got an implantable device who can be hacked as they walk, as they're sitting on the bus, as they're in their home. As I stated, we're in a mass digitization right now. We want everything on the network. We don't care how it gets there. That is the model right now in healthcare. We don't care, get it on the net, get the data. We want to extract the data and interpolate it and put it in our EHR. Because why? Darn near every device we have has some sort of data that we can use. So you'll see lots of devices, like I say, by using middleware. So at our hospital, we have over 4,800 devices communicating on the network. 4,800. Really, only about 1,200 of them are designed to do so. So we have all these extra pieces of middleware floating around attached to these devices that can be, stolen, hacked, all the above, okay? So that's where a lot of healthcare providers are. It's too expensive to replace. These medical devices cost thousands and thousands of dollars. A very simple device that you would think would be moderately priced is easy in the ballpark of $5,000 to $15,000. So imagine if you need a few hundred of these devices. It's just too costly. So it's easier to buy a box and throw it in between. This is another example of what we try to do when we're trying to connect old dinosaurs. So this is a 40-year-old device. You won't find this used anymore in hospitals, but for the sake of the example, I've got a red circle with a little arrow pointing to, hey, we've got a way of extracting data from this device. Let's see if we can get it on the net. That's kind of our job. That's our role right now, is trying to get these devices on the net, on our network, in order to get the data from it. So, just like ICS, your industrial control systems, they have stuff that's been around forever. Once you implement, you don't touch it, you leave it alone. That's the same thing with some of our devices. So we can't often touch it, we can't upgrade, we can't update, but we can find a way to extract that data and get it to where we need it. And then what happens? There we go. Yes, sir.
So, in looking at industrial control systems, controls that were made 30 years ago were still, working. And they built cybersecurity into those interfaces, if you will, the middleware.
Sure.
Are there similar type solutions in the medical community for some of these devices that give you some versus none?
Yeah, they implement protocols, whether it be through VPN or some other encryption protocols. They do implement those types of things, but not as well as what you're referring to. So, but yeah, we use a lot of, like I say, middleware, physical. They look like small switches, and their sole purpose is to connect, again, a bunch of devices and then translate the information. So they actually do the extraction of the data and then put it in HL7 format and then get it to a gateway. But then as a technician like myself, we often find ourselves in this kind of a mess. I don't know how many of you have experience in data closets. This is not uncommon. So we're trying to interconnect our devices. Like I stated, we have thousands of devices now in the network. We end up in a spaghetti string mess like this, trying to get those devices to communicate, which also poses another security risk. For one, we have no idea where anything's going. Nothing's labeled, nothing's identified. We're just plugging and chugging and trying to keep our hospital running, keep our clinicians happy. All right, here. The keyboard, maybe. Okay, so the other thing that we're finding, that the other stuff we have is RF. If we aren't, or any type of wireless signal for that matter, if we're not connecting it through some piece of middleware, if we're not doing it with Ethernet or a network jack, we're doing it wirelessly, whether it be Bluetooth, 802.11, Zigbee, whatever it may be. So you can see in this room, this is not unreal. There are numerous, if not more than this, devices that are producing or emanating RF signal. Some of these signals are very easily, we can crack them in a matter of minutes. Okay, we can capture these signals all day long. We can extract patient data from these signals and some of these devices, and they become very easily hackable. But as you can see, this is a standard ER room. So if you were to become injured and they drag you into the hospital, this is what today's standard emergency room looks like. But we have everything from patient monitors to even our clock. Our wall clock is now wireless. We've got wireless sensors on our lights, our surgical lights that you may see, due to temperature, things like that. Our defibrillators are in the room, and there's stuff shoved in our medicine cabinets that is also wireless. So what are the risks? Excuse me, what do you think about when you go to a hospital? What are these things that come to your mind when you step foot to your healthcare provider's office? You don't think about cybersecurity. You don't think about the medical devices. You think about yourself. You think about a loved one. You think about why you're there. You want relief, whatever it may be. That's your purpose. That's your reason being there. You don't ever think about what could happen. You don't think about, other than maybe a missed appointment, something like that, the risks that are occurring right now in healthcare. So some of these risks are insanely vulnerable. They're easy. They're happening left and right. We're finding them in our newspapers every day. The headline here is, it's insanely easy to hack hospital equipment. Medical researchers were thrown into a hospital. They were given free range, and they found that they could change drug delivery dosage. They could change all this in infusion pumps remotely. They could change settings on defibrillators to get the defibrillator to either fire or not fire at a particular time when it's requested. They could deny the service, or again, they could implement it to make it discharge while not intended to. Refrigerators, freezers, we store bones, we store organs, we store blood, we store this stuff in these pieces of equipment that can be turned off remotely. Again, we have pumps that are utilized for your care delivery that if we can manipulate the dosage, we could kill you. And the other is the implantable medical devices can be hacked to harm patients. Just as I stated before, it's been proven numerous times that individuals can hack their own. There are researchers who are, they've already debunked this, they've already found it's true, and they've moved on to the next thing, This is an interesting slide. You're all familiar with Shodan. And what medical researchers found was, within a matter of 4 to 5 minutes, they found about 36,000 different medical devices communicating on Shodan, or found through Shodan in a matter of 4 to 5 minutes. 36,000 medical devices. They can specify all the way down from the state, the city, to the facility. And I know at some point in time you've all used this website. I believe you get a free account with an EDU email address or premium account. So that's a scary thing, that our medical devices are out there communicating on the net. They're communicating in the World Wide Web in ways that are easily attracting attackers and hackers. Keep pushing the button. Here's another one where security researchers found a backdoor on an MRI scanner. So the big round donut with the table is magnetic resonance imaging scanner. It's about a $2 million device. It's so expensive, most hospitals only have one of these. If they can afford more, they'll have more. But it's a critical asset to the organization. In fact, some organizations would probably shut their doors if they don't have access to some of these types of devices. So a $2 million device where medical researchers found, or security researchers found, that they were exfiltrating patient data for months, unnoticed. No one ever noticed. No one had any idea. So they had a backdoor just deliberately taking data. And these devices produce gigs of data per patient, per day. And then the other statement next to it is, no one is thinking about a CT scanner or an MRI machine as a broader launch pad, or as a launch pad for a broader attack. Absolutely, I am. That's one of my biggest concerns, is knowing that there's only a few of these devices in each organization, or each healthcare delivery organization. They're very easily, it's public knowledge on what they have, what make, what model. We know what's available. We know these devices go unpatched, untouched, vulnerable for many, 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 many years. And most hospitals don't just replace these every 2 years. I mean, again, at $1 million to $2 million, we may try to keep these for at least 10 years. As a time and material customer, we don't pay for contracts. We don't pay for free upgrades. We don't pay for software. Our device is working, we keep it the way it is, and my responsibility is to manage that device, so I keep that device working. But if we don't have upgrades, we don't have these things because they're just too costly. You know, $40, $50, $60 to $100,000 to update the system isn't really practical. So these devices are extremely vulnerable. Most of these devices are sitting on XP. They've never been patched. They've never been touched since 2013, 14, 15, whatever. And they'll stay that way for years. So having these devices known with these vulnerabilities, we know that my facility might have 3 of the exact same. You know that IU down the street might have 3 that are the exact same. The ability to utilize an advanced persistent threat and use these machines and then maybe shut them all off at the same time. You know, yes, sir?
So that's history. Going forward, are hospitals now putting in specifications or requirements for cybersecurity that's upgradable over time?
We request it. There's nothing mandatory at this time. The device manufacturers have a hard time thinking they have vulnerabilities. They have a hard time thinking it's their problem. Oftentimes it's seen as, well, the device has been sold, it's in your organization, it's your responsibility to protect and maintain. There's too much money involved for the whole process. So the FDA and the government has asked that manufacturers start implementing controls. And as a healthcare delivery organization, we ask the provider who's going to sell us a product, do you have these controls in place? Otherwise, we're not going to purchase your product. So, yes, sir?
So what about containment, right? Instead of patching, you can contain.
And that's partly, somewhat, because our users still make this device vulnerable. Our users are still notorious for plugging in flash drives. They're still notorious for charging their tablets. They come with basic computers. They sit right there in front of the user, and the user is going to go charge their phone. I've caught it. I've seen it. It's happened numerous times. So yes, and I'll talk about containment strategies at the very end. So yes, and that's an approach we're looking at as healthcare delivery organizations, because we don't have the support from our manufacturers. And we don't have anti-malware, antivirus, anti-anything specific to these devices, because sometimes as a delivery organization, I don't even have access to the operating system. If I go to install something third party, I void anything. I void warranty. They can't promise me how the system's going to behave. Now, I've taken devices out of service and poked and prodded and tested. But if I go back to the manufacturer and say, hey, I think it's okay, they need to validate that, not myself. So they're not going to trust my results. But that's what we're in the process of doing. I've been taking devices offline and scanning, installing, and evaluating to see what kind of changes are made, what's happening. But yes, I will get to some of our control measures Here's another one. Massive ransom cyber attack hits nearly 100 countries around the world. You're all familiar with WannaCry. And as sad as it is, as a healthcare delivery organization, that was our wake-up call. That was our holy crap moment. Because we didn't know what to do. We weren't affected. My organization wasn't, but the organizations next door were. And you're getting phone calls and hey, did this occur to you guys? Hey, what are you guys doing? Hey, we're getting those calls more frequently now. You know, we're sharing information on what's happening, and it's more predominant than ever. So again, this is exactly 16 hospitals were shut down in the UK. Shut down. So if you think about this from a cyber perspective, if this hit all the hospitals in this area, if this hit all the hospitals in Indianapolis, you could totally deny service and care for anyone. You're in a trauma, you have a heart attack, something's going on, you're sick or injured, we have to turn you away. You know, again, as a cyber attack, this is a huge problem. Now, a lot of our IT systems are protected. They're updated, they're patched, we have intrusion detection systems, we have the anti-malware, we have ways to circumvent that. But I just stated our medical devices don't. So as long as it gets in, it can find its way around very, very easily. Protocols, ports are open, things like that. And the best and fastest and easiest way it gets in is by a user. And we'll talk about phishing. I mean, you all know how phishing works, but I'll show you how easy it is, and it happens all the time in healthcare. All the time. This happened just January 17th. It actually happened in December of 2016, but Hancock Regional Health paid a ransomware, $55,000 to attackers. They didn't get a medical device, but they got some computers, some databases that had patient information on it. So they paid the $55,000 ransom. You're finding this in the newspaper every single week. As you can see, if you ever want to see your data back, you're going to pay this price. And it's very scary. And again, closed due to malware. We absolutely will close our doors. I have 3 CT scanners. If those 3 CT scanners go down, we cannot service patients. We're a level 1 trauma center. We'll have to divert any patients that come in, make them go to another facility, and duke it out one way or another. We don't have implementations in process yet. Now we are working with the local government. We're working with our other healthcare organizations to develop an action plan. So we're working with MESH in Indianapolis to find a way. What is the approach? If this happens, what are we to do? Now, what some researchers say is 1 million vulnerabilities. So I'm going back to medical devices. I'm talking about a physical medical device now. And what a lot of these researchers have done when they've spent hours and hours and hours researching the vulnerabilities on these devices is, yes, they have found 1 million, they've found hundreds of vulnerabilities on one device. But which ones affect patient care? Which one is that potential to kill a patient? Which one's the one that's going to cause an adverse reaction? We don't know. We could talk about MITRE scores and see common vulnerability scores and all that fun stuff all day long. We can calculate risk all we want. The likelihood is always going to be there. We can't determine the likelihood because it's guaranteed. But we can't determine exactly which vulnerabilities are going to hurt a patient. So again, if we have numerous, we have hundreds, which ones? Which ones? So the focus on penetration testing medical devices has shifted. Okay, again, okay, yes, like I say, we can find that there's maybe thousands on this device, but again, which ones are most significant? And then what some manufacturers say, there's nothing here to see, move along. They don't want to fess up. They don't want to necessarily publicize that maybe there's a vulnerability because, again, we don't know which vulnerabilities are going to have an impact. Also, the way the equipment was designed is often different than as implemented. It was designed to work in this setting, but us as healthcare delivery organizations have implemented it in a different way. So when we implement it in a different way, we often create more vulnerabilities. So again, it costs more time, research, money, and effort for a manufacturer to fess up, to do their own. Now, there are many that do participate. I've gone to a few conferences where they're very open. Hey, help us. We want to know. They've asked me, they asked several of us from delivery organizations, what do we need to do other than basic secure coding practices, textbook stuff that we're all familiar with. They want to know what they can do. We need more hard-coded security pieces in place, written into the software. We want encryption. We want mutual or multi-factor authentication. We want maybe biometrics. We want things that can help. So again, there are many that are participating, some are not. What some black hats say, again, vulnerabilities. We's on it. Okay, they'll find them, they're going to look for them, they're going to continuously analyze and look for those vulnerabilities. Hospitals are very, very easy. If you think about it, again, you walk into a hospital, we're an organization where we care. We want to know what can we do for you, but we can't monitor everyone and everything. So if you come up to a kiosk and you're going to play around in a kiosk and you're going to inject, you're going to insert malware, or you're going to do your SQL injection, or you're going to do your cross-site scripting, whatever you want to do, who's going to question you? If you want to sit there and bring in your laptop and start cracking our wireless passwords, who's going to stop you? Nobody. We might have you on camera, but 200 days later is by the time we figure it out. It's pretty easy. And what the problem really is, there's numerous problems. Again, with the medical device manufacturers participating their way and healthcare delivery organizations looking for a different approach, it's hard. We don't have a direct answer. The problem is medical devices now aren't just a physical device that produce therapy or an infusion or diagnostic. We have now implemented devices that may look like this. A physician or surgeon may plug something into his iPhone. What constitutes a medical device anymore? When we take a scope, we take an endoscope, or we take something, and the physician now wants to plug it into his iPhone and view the images or the recording on his phone. Which part of that is the medical device now? So there's a lot of skewness here. We don't understand necessarily anymore. The gaps, are getting bigger as we again look more at mobile health. So again, when the definition of a medical device is it's an instrument or an apparatus, a machine, implant, or in vitro reagent, or other similar or related article, including a component part, an accessory, intended for the use and diagnosis of disease or other conditions, or in the cure, mitigation, treatment, or prevention of disease. It's pretty broad. It's really broad. So where in there is software? Where in there is the iPhone? Where in there is that information? It's not. So again, that being a medical device, sometimes the information technology department, the IT security department, they don't touch these devices that communicate. So when the doctor plugs in his scope into his iPhone, they don't have anything to do with it. That's on someone like me. That's our healthcare technology engineers, our clinical engineers, we often call them, inside the hospital to maintain those devices. We may not even know what he has. We may not know what's available to us. And I'll cover that in a moment. So the threat landscape here with medical devices is rather significant. So U.S. healthcare delivery organizations have been victims of one cyber attack per month over the past 12 months. On average, all of them. Half of them have experienced some loss or exposure to protected health information. And the most common security incident is the exploitation of existing software vulnerabilities. Not patching, not updating, not even understanding what your assets are, exactly all your inventory. So about 43% of about 43% of breaches are due to insiders, our own people. So yes, 27% is from hacking. It's from individuals wanting to steal that data. 19% are from lost or theft. A lot of people steal laptops. Clinicians take laptops home all day long. I take a laptop home. We have security practices in place, but as you guys already know, it's pretty easy to crack those. But our insiders through phishing scams is the biggest. Click here and resubmit, or your credentials have been lost, or stolen. Please re-enter your credentials. All day, every day, we get these emails. And so clinicians are often very giving of this information. They're busy. One nurse might take care of 6 patients at a time. So when she's obligated to check her emails and she gets an email and it indicates, hey, this is IT staff, we need you to reinitialize or reinsert your password or whatever it may be. Sometimes they are notorious for doing that. Not saying just clinicians, we all are, because we lack awareness. Now we are on the brink of teaching it. We're implementing methods of teaching it, but again, as we just discussed, clinicians care about their patients. They don't care about what's on that computer screen unless it involves their patients. So is hacking or healthcare hacking an epidemic? So one of the most notable here is Anthem. in 2015 was hit with 78.8 million customers being hacked. I was one of them. The best they could do for me is give me LifeLock for, what, 2 years, I think it was? That's the best they could do for me. I don't know where my data is. I haven't seen it. Nothing's come about from it yet, so we'll get to that, though. SANS reports 94% of healthcare organizations have been the victim of a cyber attack. Some of them don't even know it. The healthcare sector ranked second in US data breaches in 2015 and secured a spot on Verizon's global hacking report. And about 47% of the US population have had their personal healthcare data compromised over the last 12 months. 50% of that 47% had an average of $2,500 out-of-pocket expenses. How does that happen? Someone steals your identity and they assume it as their own, and then they get medical procedures done under your name, under your information, and then you get stuck with the bill. This isn't the FDIC. It's not a credit card. It's not a social security number where you're federally insured and you'll get your money back. You have to pay that. Someone's paying that, and it's you because it's in your name. It's in yours. There's numerous stories. Back in 2011, some Chinese hackers took about 2,000 x-rays from a medical facility, and they did it so they could pass their medical exams so they could get their travel visas. So it's not just about money. It's about everything. If we want to, like I say, whether it be a denial of service attack, whether we want our travel visa or they want their travel visas, or they need their medical procedures done and they don't want to pay for it, fine, we'll find a way to make someone else pay for it. You know how expensive medical procedures are? Yeah, they're not, it's a mortgage, it's a house. It's not cheap. So for the X amount of years lately, it's been the wrong mission, outdated approach, and it's been failure. We've been focusing on patient records. I've been talking about PHI, I've been talking about EHRs, so protected health information and electronic health records. Electronic health records, and I'll say this repeatedly, I have another slide on it, are very valuable. If you think about it, what is on your electronic health record? Not the one you might log into on your mobile app, but the one that's actually stored at the hospital. Everything about you, every disease you might have ever had, every person related to you, every job you might have had, every last 10 places you might have lived. So we have everything that we need to know about you. So again, we've been focusing on patient records, and that's not really the case anymore. We've been ignoring some of the advanced threats. Maybe boil back to that CT scanner and launching a broader attack, a globalized denial of service in healthcare. And patients just simply aren't protected. So there's another problem. Who owns cybersecurity in healthcare? So cybersecurity leadership structure differs across the globe in healthcare. Only about 67% of healthcare organizations have a CISO. 32% don't, and whoever took the survey, 1% just have no idea. And budgets. 65% only dedicate 6% or less of their IT budget to security. So minimal when it comes to millions of dollars in budget go to security. That's changing. The problem is, what's the return on investment? We know what the server costs. We know the expected life expectancy. We can calculate it all day long. How about some of these security measures? How can we calculate what they're going to stop? How can we calculate that this $60,000 device or this enterprise solution is going to stop ransomware? That might cost us who knows what. We don't know. We can't calculate that. So a lot of C-suite members are very reluctant to distribute funds to security yet. As we start to see this ransomware in the newspaper every week, you're going to start to see them come up off that a little bit. Actually, our organization is asking, hey, what can we do? What do we need? We're getting more and more funds each year to start analyzing, looking, and applying new controls and compensating controls for this. But this is crazy. So why is healthcare getting hacked? Why? Lack of aid. We don't have funding. We don't have money. We don't have resources. So as a healthcare delivery organization, people in my department lack some basic information security knowledge and skills. We do, so the individuals who take care of the equipment may not have a fundamental understanding of some of this stuff. We're understaffed. our focus is on maintaining the devices. We want to ensure it's safe for the patients. We have to perform preventative maintenance on these devices. We don't necessarily have the time to ensure it's safe in the cyber world. Again, undertrained, there's not a lot of information pertaining to medical devices. What do we do with cybersecurity and medical devices? You know, sure, we could take a class in cybersecurity, but that pertains to information systems. Yes, we have an information system within a medical device, but we also have the medical device itself. Ease of network intrusion. We've kind of discussed this. Rather than outside coming in, or excuse me, external penetration coming in, you can just step foot in the hospital. You can get your hands on stuff. You know, if you want to go walk into a suite, and even an OR if you wanted to, an operating room, you could do so. Okay? There are mechanisms in place to prevent you, but it's relatively easy. You know, you've learned all about reconnaissance through hacking and whatnot, and what individuals will do to get dumpster diving. All this information, you can do the same thing at the healthcare facility. The information is just too good. We've talked about PHI, and we've talked about the information in your electronic health record. It's too good to pass up. It's sweet. We have so much of it, and we don't know how to handle it. So you can come and get some. Hackers' competence or healthcare delivery organizations' technological incompetence. It's a mixture of both. Because I can tell you, we can stop the typical script kiddies. You know, an individual who lacks any true competence, yeah, we can prevent them from getting in. It's the hacktivists and some of the nation-state people that and organizations that are what's troublesome, the ones that are familiar with advanced persistent threats and coding and things like that. But again, we don't have necessarily the tools and resources in place. You know, our security teams are small. Some of it's outsourced. A lot of and some organizations are just buying cybersecurity insurance. You know, forget it. We'll just take the risk. We'll just buy insurance. So here's more on the threat landscape. UCLA claims they block millions of known hacker attempts each year. 171 million patient records were exposed since 2009. I believe that number is much higher now. But an increase in 137% in PHI breached from 2012 to 2013 alone. Consistently increasing. 1 in 204 emails contain malware to clinicians. So some sort of malware to a clinician. 1 in 204. It takes us on average about 200 days to discover a breach. Denial of service attacks cost about $1.32 million per organization in the last 12 months. And about 1,000 ransomware attacks per day. So our assets, our health records, that's our biggest asset, and our patients, obviously. Our patients' health, our records, our service availability, our ability to maintain service and give you service and provide you service. Our community confidence and trust. If we're constantly hacked, if we're constantly shutting our doors, are you going to come for your procedure to our facility? Absolutely not. You're going to go next door, you'll go somewhere else. Intellectual property. We may have information that's proprietary or specific to us that keeps us business a competitive advantage. Again, boils with business advantage. Finances and reputation. These are our assets. Physician reputation, healthcare reputation, organizational reputation. So who is hacking healthcare? Numerous. Now I talked about script kiddies. They're at this point kind of worthless. They can't do much damage. We're pretty well protected against them unless they get inside and they use some basic tools. But our hacktivist groups, which are more notorious, well, I'll cover that in a minute, but our cyber criminals, our cyber terrorists, and our nation state actors. So if we look at our topology of threats here, we have an adversary who may be a hacktivist, and he's here on the left, and he's just kind of looking around. He's doing his recon. He's looking at something untargeted, meaning he's just choosing a hospital with the biggest reward and the lowest risk. So he might look for something like my facility, compared to the facility next door, which is a children's hospital. Because maybe a children's medical record isn't as good as someone in my facility. Or maybe we have a private facility next door where we know everyone's paying big dollars for procedures over there, cosmetic procedures. That might be better. That might also be less risk. So these types of adversaries aren't looking for anyone in specific. They're just looking for the gold nugget. They just want the whole thing. So they're going to try and get as many records as they can with weak security. Where an adversary who's targeting someone, again, might be an activist or hacktivist. It might be a nation-state group. They're looking maybe for political targets, maybe people of famous, blackmail, things like that. That happens all the time. I hear all the time about healthcare workers on accident or on purpose looking at records they shouldn't be looking at. But these organizations do the same. They might look for someone who's of value and blackmail. So again, the adversaries' profiles. So this kind of depicts two different things. There's patient records and then there's patient health. So if you look at the adversary of individual or small group, your script kiddie, they don't care about harming a patient. They lack the skills and the technical ability and maybe even the time. But they do care about patient records. They're going to untarget, not discriminate, and get whatever they can and get out. Then you have your political groups and your hacktivists, which are going to look for targeted victims, and they're going to look at patient records. Again, they might not care about that individual's health. They just care about their record. Then we have our organized crime, who, yes, they might target someone. And yes, maybe they are looking to cause harm to that individual. Same thing with if they want their records. And obviously our terrorism and our nation states are across the board really looking at individuals. They're looking at hurting and harming people and obtaining records. So this came from independent security evaluators. It's a nice graph and it might be a little blurry for you, but it's a patient health attack model. And what it's really boiled down to is you have your patient in the very center and you have your exterior, where some information can be extracted or penetrated. And attackers are basically trying to penetrate into the center where the patient is. So the outside might be where your PHI and your PII is. It might hold sensitive information, non-sensitive information, your records, things like that. But the inner circle there with the physician, the surgery, the active medical devices and medicine is going to be targeted towards an individual. Attackers may look to try to harm a patient by modifying, again, drug delivery dosage. Maybe they're going to try and change surgery schedules. You ever think of a hacker going in and changing your procedure? We've heard of wrong site surgery before. Maybe someone made a mistake. Well, how about they actually go in and they change that you're supposed to get your left leg amputated and you end up getting your right or something else done? Yeah, that's feasible. That's possible. Okay. Same thing with stopping the physician. Maybe they know the physician. Maybe the physician's high profile and they'd like to do something to that physician to prevent them to offer the service to you. Why? Why do they do it? Why do we care? Why do you care? Because for one, it costs you money. Whether you ever step foot in a healthcare facility, whether you care about being a programmer, whether you care about working for a medical device manufacturer or working for a hospital, at some way, shape, or form when it comes to public health and it comes to hacking and what's going on, you might be paying for it. So right now, it's estimated that Social Security numbers are about $15 on the dark web. Credit cards are almost worth nothing, $1 to $3, and as time goes on, that'll disappear. But your medical record is worth anywhere from $100 to $500. It just depends. And if you think about it, one medical record is fairly easy to get. I can get a whole stockpile in one swoop. I can attack one database server and get hundreds or thousands. Put those on the dark web, package them together and sell those. Big money. That's why. 3 reasons why you should care. Again, your health records are currency. We've already talked about an individual or group or nation state possibly doing things to you and your information that you have to pay for. I've read in some instances where out-of-pocket expenses averaged $18,000. I was in class with an individual. We were in Cleveland, and he disappeared for 2 days. He came back. It was a 2-week class. He came back, and he had informed me that the FBI had picked him up. And the FBI had picked him up and was holding on to him while they were doing some research in another state on someone who had assumed his identity. They were having medical procedures done, and they were able to determine that he was in Cleveland at the time. And they asked him to stay, under the radar for a couple of days so they could try to pick this individual up. Needless to say, I think they told him he was currently in debt at $44,000 for some of the stuff that was going on with his identity through his medical health record. Your hospital cybersecurity might be leaky. Maybe not yours, but mine. My information is everywhere. I told you we're kind of careless sometimes with it, needless to say. You know, we'll give it out freely. We'll find, you know, patients need this information. It's always readily available. We have this model, and I know you're familiar with the model too, when you're trying to protect a system. You've got a choice. You know, do you want full security? Do you want usability? Do you want availability? What do you want? You have to move and determine what suits you best. Well, in healthcare, of course we want security, but we can't. Once we add and have all these controls in place, we take away from the clinician's ease of use. The clinician says, forget it, I don't even want to work here anymore. Too much security, I can't do my job, I'm out. And that's kind of the ball we're playing right now. So we make things easy. You saw that meme about, you know, I can function, I can work a medical device. Medical devices are carrying more PHI than ever, and they're super easy to use. In fact, many don't open the operator's manual and they just learn as they go. You know, they may have been instructed in nursing school and nursing class, but very frequently they don't open the operator's manual. So it's very easy to let that information escape. You might be missing the biggest flaw in cybersecurity. So from 2015 to estimated 2019, they say about 1 in 3 will be impacted. 1 in 13 patients will have some sort of data breach. So you can see from the graph here, I'm kind of looking at 2019. We're talking in the millions. So the light blue color there, we'll have about 7 million patients impacted from a data breach. Now, impacted doesn't necessarily mean you're in the tank. They've taken everything from you. But it means they've collected information on you or possibly collected information on you. Where then in the dark blue there, the 1.7, you've been victimized. They've done something to you. And then in the green, you're stuck paying for it. So the OPP means out-of-pocket expense. You're paying for it. Okay, so those numbers are going to continually increase. You can see from 2015 it's 0.56 in patients paying out of pocket, where about 2019 they're going to say 1.4 million are going to be paying out of pocket. I don't know about you, but coming out of school and having maybe some student loan debt and then finding that you owe the hospital some money, it won't be fun. So why are medical devices so vulnerable? They lack, or we lack, talent. Fair enough. Individuals like you aren't focused in healthcare. You get all the others that come in here and maybe your attention's drawn to ICS or you're going to the automotive market or wherever you may be going, that's fine. But we lack talent. We have CISOs and we don't have dedicated teams that understand the infrastructure. Some of that textbook stuff you learn doesn't necessarily apply, again, because we have patients, we have clinicians. We have to find a way to make it work. We have to adapt. That's why some of those NIST specifications just don't necessarily work. Legacy equipment. Oh, we love legacy equipment because, for one, medical devices are extremely expensive. We can't just go replace every couple years. Even a software update can cost hundreds of thousands of dollars. So we tend to leave equipment as it is. If it works, leave it alone. And that happens a lot. Premature or over connectivity. We've talked about, we want everything on the network. We have 4,800 connected devices. 1,200 were designed to do so. Maybe we've overdone it. Web services for interfacing. A lot of our devices communicate through a web interface. So again, if you're snooping on the net in our network, you can see that communication process. You can attack that web server. It's very, very vulnerable to your cross-site scripting and your SQL injections and things like that. Because again, they were implemented with the understanding they were internal. They were in the network, so they were protected. A lack of awareness. Sure, we have cybersecurity training. Our CISO wants us to know. He sends out emails all the time. We have annual education. We have this in place. But when you're focused on patient care, again, sometimes those things just don't come to mind. Here's a wonderful article I came across just the other day about an individual, a security researcher, who this is a very basic syringe pump, but he was able to find wireless keys stored unencrypted, accessed via Telnet and FTP. He had root shell on port 23 and hard-coded local accounts. That link in there, if you go back and review this link, he gives you almost a step-by-step process on how it was done and what he did. Now, keep in mind, it took him about 400 hours to do so. And that's what we're finding, that yes, it does take time, but we've also learned that hackers have nothing but time. So if you can walk one of these out of a hospital, which is very easy to do so, you see that. It's no bigger than the device here. It's not much larger than that. You could walk out with that. We have patients walk out with them all the time, still connected. They leave or they're transferred or whatever, and we may never see it again. Okay? So remote code execution on this device. So I've got a couple slides here on, again, why they're so vulnerable. Legacy operating systems. They lack timely software updates. So even if we do have a Windows box that does get updates, we have to have the manufacturer validate those before, and they're not necessarily so quick to do so. We're at least 2 months behind in most cases. So if we know of a vulnerability that comes out or a patch comes out, by the time they evaluate it and then they give us the approval for it, it's 2 months later. Again, medical devices lack any basic security features. Web services for interfacing. We have local databases on the device. So if you walk out the building with that device, it's yours. Unsecured application software. Again, we talked about first to market at the beginning. So sometimes they just scripted together some quick, easy software to interface with the device or for the device to have, so it's user-friendly. We care more about sleek, sexy, GUI-based operating systems now than ever before. Again, lack of awareness. Lack of physical, logical, and any kind of administrative controls. The passwords for these things are all over the internet. I cannot create my own password for a lot of these devices. So for instance, I have several hundred pumps, or I have several hundreds of certain devices. They all have the exact same root password, all of them. And if you want it, you can just call the manufacturer and get it. You can do a quick Google search and you'll find the exact same password. And I can't change that. If I could, I would. Devices, again, are made easy to use. Most are embedded systems. So again, they're embedded processors. I put expensive, but inexpensive, wimpy processors, limited RAM and storage. I kind of discussed the cost of these devices. So if I went back to that syringe pump, that's about an $6,000 to $8,000 device. If we were to implement better processors, so we could do encryption, if we were to implement more RAM, if we were to implement these safeguards that would help us, we're talking about a $15,000 device now. So we're talking about more money, more research, more dollars on the manufacturer side, and are we willing to pay for that? No encryption. Obviously, no anti-malware. We have very few devices. These are embedded systems. We may not be able to put any kind of anti-malware on them. Some manufacturers do enable us to if they're Windows boxes, but most don't. And our people. So here's a phishing email that you can see January 15th. That was delivered to me January 15th. Just says our law office is representing the insurance company. We need one more piece of information. Please click this link. That's all it is. So it wants me to click that link. It's a perfect, easy phishing scam. It looks pretty good, talking about need for litigation. They claim they're a lawyer. As a clinician or someone in a hospital, I might be apt to click that link. Again, some common issues: lack of funding, policies. We have a lot of technical issues. Vendors are some of our issues, and our physical security. I don't need to hit on each one of these, but they've kind of been discussed throughout. So what do we do? What do we do as we move forward? So security should be designed in. That's our starting point. We have to put that in place prior to. So we need assistance from the manufacturers. They need to start secure coding practices. You know, there's all different kinds of frameworks for how we can look at code, what we can do with code. Yes, sir?
So, I know in the controls world, usually typically the IT guys don't think that's their problem when it comes to security. And control engineers don't think about
Darn right.
security. So there's really no one kind of overseeing it. It sounds like you have a similar situation.
Exact same problem.
In your world. Logically, where should that focus be? The IT world, or it should be like your organization?
We're trying to find that line. We're trying to determine that. Myself, I'm training, I'm researching to cross that line, to work with our CISO. I'm presenting him with this information, like, look, we have these problems, and he doesn't understand. Well, I don't want to. He may not understand exactly how our devices can be interrogated and what they're capable of. He understands his side of the story. So yes, we have that gap. So the problem is most anything IT security, IT infrastructure. Once it's an FDA medical device, that hands off. They don't touch it. That's kind of that line. So a lot of these are, or all of them are FDA medical devices. So we're finding that we're choosing to cross that line. But we have a lot of third-party organizations that service medical equipment, and that's all they do is service medical equipment. They are not going to implement or do anything with security unless the customer wants to pay for it. And right now, we're trying to stress that significance. So we're in the infancy stage of really trying to get that out there. That someone needs to step up and find a way. But absolutely, same issues. It can't be bolted on. We're finding that we're bolting it on now. We're coming with the afterthought of, hey, let's try this. So I'll get to that here. But like what we talked about earlier, what are we doing? Cybersecurity Act of 2015 created the Healthcare Industry Cybersecurity Task Force, more or less defining roles, finding out how to get money, grant money, what to do with that money. We have some executive orders that talk about critical infrastructure. Same thing, kind of what are we going to do? How are we going to? It's a lot of planning, policies, and procedures in place. And then 691 is promoting information sharing with ISOs. So I've done some work with this. We've looked at these vulnerabilities and we're trying to share this information with ISOs, and that's what we're trying to do currently. But as we kind of stated, even if we have hundreds and hundreds of vulnerabilities for one device, what does it mean? And then the FDA came out with a post-market management for cybersecurity and medical devices. They're asking the manufacturers to help. They're saying, hey, can you do something with your devices that are already out in the field, whether it be patching or whatever, those kinds of things. So what are our challenge for healthcare delivery organizations? We may not even have complete inventory assessment. It sounds ridiculous, but I told you we have 4,800 devices, but if you go next door, they may not know how many devices they actually have communicating on the network. So we need better tools for integration to determine this. There are many manufacturers out there that are developing these kinds of tools, but they're just so darn expensive. We can't, we're talking about $1 per device that's communicating on the network. Not just our devices, but all devices. So if there's thousands and hundreds of thousands of devices on the network, we're talking big money right now. We have to integrate some of our security into what we call our CMMS database. That's our management database for our medical devices. Just like IT, all medical devices are assets. We classify the assets, we code them, we risk them, and then we put them in a database so we can manage them. So we need to integrate security features into that. We need to know what firmware level they have, what operating system they have, what they have. Because what if the next big thing comes out and we don't understand what we have? What are our revisions? What level? Is this Service Pack 3? Do we have Windows 7? A lot of organizations don't know. That's the scary thing. They don't know what they have and what versions and levels they have. Again, vendors make it hard. Maybe no patches or they're delayed. We're always a couple months behind. They'll sometimes give us incomplete responses. They'll say segment it or put it behind a firewall. They'll sometimes refuse to cooperate. There's these MDS2 forms that we're asking for. This is our healthcare delivery organization's way of saying, hey, how are you making your device secure? So the security team at the manufacturer will fill out these forms, answering basic questions. It's almost like a risk score, a set of risk questions. And then as a delivery organization, we'll assess it. We'll say, okay, you allow antivirus, you allow this, you allow encryption. That's what we're looking for, and that's what we want from the vendors. Some aren't filling those out. Again, limited resources, too much data, not enough people, lack of cyber education, no time, too much regulation on maintenance. They want us, we're required to do maintenance and complete our maintenance on our devices. Again, segmentation is not enough. No specific anti-anything for medical devices. No one's created anything that we can just install. It's here, we're protected. So VLANs, access control lists, is not cutting it. Blacklists and whitelists become incredibly hard to manage. How can we do this with all of these devices? We have limited and no support from anti-malware. And then back to the question earlier, we're looking at enterprise solutions. So some of the things we've done is we've purchased next-gen firewalls that have a management console, and we'll plug these into certain devices, and we'll create whitelists and blacklists and VLANs within these devices, and then we'll use the enterprise solution console to help us manage those devices. But now we're still talking about plugging in $500 boxes behind 4,800 devices. So now just another device tagged on to another device. So cybersecurity, it's a foreseeable risk of sabotage. My point is, yes, we can see hackers are breaking into medical devices. It takes time, it's doable. but that's okay. That is. The wide-scale unavailability of patient care is what our concern should be. The ability to create a denial of service to a whole healthcare organization, to a whole city, to a whole state could come about. So the integrity of medical devices is one of our biggest risks. Our gaps, again, are procurement, our life cycle. You know, when do we start retiring these devices? When do we say, hey, security is not enough, the device has to be retired, how do we purchase new? So our procurement process and life cycle. Again, we may not know our clinical inventory. That's a big gap. Many organizations, because doctors, nurses, sometimes they just bring stuff, they buy something at Walmart, they buy something online on Amazon, and then they just say, oh, I'll just plug it into the network. No one may ever know it even exists, and they may be using it. So again, our challenge is still training, job roles. We don't have a specific job role right now that can manage this type of work, that can integrate with the IT security, IT as well, the infrastructure and network guys and database guys, and then the biomed clinical engineering side. Many specialists focus on technical controls. Too much technical. Can't do it when we're trying to provide patient care. And many safety specialists focus on risk management. Again, we know the risk is there. We need to protect the patients. That is all I have for you. Questions? Do we have any other questions? Yes? Maybe?
Yeah, we're a little bit over time, so maybe we'll take the questions offline.
Okay.
If you stick around for a bit.
Sure.
So we'll do that. Thank you.
Sure. Thank you.